From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome. This is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. Today we're talking about healthcare for people in prison. This is a big issue. The United States locks up more people per capita than any other nation, and this number has grown dramatically over the past 50 years. Gaps in healthcare for people in prisons can worsen their healthcare problems, with repercussions for the prison system as well as communities when prisoners are released. The study we'll discuss today shed some light for me on this issue. I learned some disturbing facts about how the prison healthcare system puts barriers in the ways of needed care. So I'm really looking forward to talking with our guests today. Dr. Emily Lupez, the first author of a paper titled Health Access to Care and Financial Barriers to Care Among People Incarcerated in U.S. Prisons. Dr. Lupez is a general medicine and primary care fellow at Cambridge Health Alliance and Harvard Medical School and will be on the faculty at Boston Medical Center this fall. We'll also chat with Dr. Ben Howell, author of a commentary on this paper called Harming Health by Imposing In-Prison Copayments. Dr. Howell is an assistant professor in general internal medicine at Yale School of Medicine and faculty at the SAGE Center for Health and Justice. So welcome, Dr. Lupez and Dr. Howell. So I'll start with you, Emily. If you can tell me, why did you become interested in healthcare access for people incarcerated?
Well, first of all, thank you so much for having me. I'm really excited to be here today. So during my residency, I was at a safety net hospital, and that meant that we took care of a lot of people who were incarcerated. And one of these patients in particular shared with me how difficult it was for him to access care, even after being shocked by his ICD multiple times. And his story really stuck with me and made me inspired to learn more about this issue. So when I started looking into this, what I learned was really shocking. I found out that access to care in prisons is oftentimes really poor, and that this population has a lot of health conditions. So it's not a young and healthy population that doesn't have access to care. It's a population that is getting older due to mandatory minimums and long sentences, and a population that is experiencing accelerated aging due to the stressful conditions of prison. So it's not a population that, we would just think, oh, maybe doesn't need health care. And what was probably the most shocking thing that I learned was that people are often charged copays for medical care in prison, even though prison jobs pay as little as 4 cents an hour, and that's if they're paid at all. And there's really not a lot of national studies or any national studies on this topic to better understand how widespread of an issue this is. So we wanted to use the most recent and the best health data on people who are incarcerated to further explore this issue.
One of the things that struck me from your paper was that some of this care was for things that we don't think of as sort of optional, like prenatal care or care for someone who has an ICD and is having shocks. So I wonder if you can talk about the impact of that lack of care on health, on what happens to folks while they're incarcerated and then when they try to re-enter into the healthcare system after.
It's definitely striking, and I appreciate the work that Emily and colleagues did. But you're right, it was a range from prenatal care, care for chronic health conditions, and the highest rates of unneeded care that was needed but with not access was for mental health conditions. I think it was close to 1 in 2 people who had a chronic mental health condition said they weren't accessing care, which is shocking.
Yeah. One of the things that's important to think about is the impact of delays in care and people avoiding care due to certain barriers, such as copays, and this leading to people only seeking care when they're in crisis status.
Do you think that the copays had an impact on how likely people were to seek care earlier before they were in crisis?
I certainly think so. Our study was a cross-sectional association between state-level copays and self-reported access to care. So we don't know what the individual experience of people are based on our study, but we do believe that copays are acting as a barrier. There have been other studies that were more qualitative in nature that have interviewed people who said that copays were a barrier to care and that waivers for copays are not appropriately applied, and people often don't reap the benefit of a copay waiver.
Could I just step in and ask, what do you mean by copay waivers, and how often is that a possibility for people?
Yeah, we actually did a deep dive on the copay policies for the 39 states that still have copay policies at this time, as well as the Federal Department of Corrections, to better understand this issue of waivers. And basically, a copay waiver is when a copay does not apply to their visit because of certain qualities of the visit, such as having a chronic condition or being pregnant. So waivers, I think, are one of the things that states and the federal government put in place in hopes of not impeding needed care. However, what we learned when we looked into this was that 85% of policies that actually had a waiver had critical restrictions on the waiver, such as only applying if the visit was initiated by the clinician or prison staff. So, for example, in our study where we looked at the outcome was ever having a visit since being incarcerated, having a visit initiated by a clinician or prison staff would require that the staff knows of a chronic condition. And this would require a visit previously with a provider or clinician. And so it seems to be a little bit of a catch-22 where, sure, these waivers are in place, but are they actually functioning in the way that they should be functioning? And some of the experts on the ground that we discussed with when we were writing our paper said that, most chronic conditions are not detected on admission to prison, and people often fall through the cracks. So, for example, somebody who has high blood pressure and has a headache, which certainly could be related to uncontrolled hypertension, they would have to submit a sick slip. And then based on them initiating the visit would then be charged a copay, even though this is a visit that could be related to a chronic condition.
Interesting. So it seems like more of a system on paper as opposed to one that can get utilized in practice.
Absolutely. There have been some other evaluations of copays in some facilities in which people who are incarcerated didn't understand the policy. They didn't understand that waivers were in place, or they knew that there are certain things that could be waived, but they didn't know what they were. And so making the system even more complicated than it already is just makes a waiver even more of an inefficient way to address copays being a barrier.
Did you get a sense in your study of the extent to which this barrier prevented people from getting care that they might otherwise have needed or found helpful?
The way that we did it in our study was we assigned people to copay groups based on their state level copay and minimum wage in prison.
Mm-hmm.
And so what that meant was that we had people in a group where there was no copay, people in a group where the copay was less than or equal to a minimum wage from 1 week's wage. And then the third group was people whose copay was greater than an entire week's prison wage, which to me was pretty crazy to even think about categorizing people into this group. And what we discovered was that 90% of people with one or more chronic physical conditions are incarcerated in states with policies that require copays. So 90% of our population is in a state where they could be charged a copay for these visits, at least for some medical visits. And then 62.4%, the medical copay was greater than an entire week's prison wage. So I think the problem is pretty extensive.
Turning now to Ben, in your commentary, you talked about the high cost of prison healthcare, that it's a fifth of state correctional system budgets, so that prisons are trying to cut costs using strategies like the one, Emily, that you were describing of charging these sort of exorbitant copays to limit access. And I was particularly stunned by you described a policy in Nevada of a man down fee. When a person is found down in their cell, they're charged $50 for the response. And again, it just seems stunning to me. So I'm wondering if you have thoughts about whether there are better ways that the cost of healthcare in prisons could be managed.
Sure. Yeah. Thanks, Eve. And I do appreciate the question because I think it's important whenever talking about prisons and prison healthcare and prison health, this conversation is highlighting how different healthcare is, how it's provided, how you access it, and even how it's reimbursed or financed in prisons is very different than other settings. People don't have insurance. They're not billing Medicaid or Medicare for the services, but healthcare is actually a line item on like the Department of Corrections budget. Mm-hmm. In the same budget that's also paying for security staff and paying for upkeep of the facility, there's just another line on that budget that's for the care of the people who are incarcerated. And so you can understand the logic of, a warden or a commissioner of the Department of Corrections saying, like, I only have this bucket of money. I want to use whatever lever I can to sort of keep costs down, because if costs go above that line item, I have to pull resources from somewhere else. So I can understand that pressure. And as we highlighted it, number one, because we incarcerate so many people, departments of corrections are a large part of state budgets, and healthcare, which is expensive throughout the United States, but especially in prisons, it is more expensive to provide healthcare. In prisons, it ends up being a large proportion of those budgets. So you can understand the motivation. Oh, we got to use something, and cost sharing like copayments has historically been a lever that people use to try to control costs, to try to focus, the consumer away from sort of too essential healthcare and away from non-essential healthcare. But I think there's a lot of literature in non-correctional settings where healthcare consumers just aren't that good at sort of making that discrimination. And so with copays being in place, they just lower healthcare utilization, both for what we might perceive as essential and what we might perceive as more discretionary or non-essential healthcare.
Something also to think about is that it's shifting the cost to the vulnerable person. It really feels like a power play here where the people who are incarcerated have such little power. They have such little finances. The minimum wage ranges from 4 to 40 cents an hour. And yet we're asking them to pay for their medical care. And this is money that also has to go towards telephone calls to loved ones or basic hygiene items from the commissary, such as toothpaste and tampons. So it's really important to think about the impact on people who are incarcerated that are having to pay these exorbitant copays for their medical care.
Yeah, and I'll just add to what Emily said. I actually think it shifts the costs in multiple ways. The vast, vast majority of people who are incarcerated now will end up back in the community, sicker and older than when they came in. And so delayed care, potentially preventative care in correctional settings, the cost of that higher cost care ends up being sort of offset to when they get released to the community. So it might sort of in like a very narrow lens, potentially reduce costs while someone's incarcerated, but that's offset by, the societal cost of providing that healthcare in the community. The other thing is, as Emily pointed out, not all labor is compensated in correctional settings. Well, labor that is compensated is at extremely low wages. Also, not everyone sort of can do work that gets compensated. And the third thing I'll say is that it ends up that when people don't have the resources from the work they can do in corrections, that means families are sending money in. And so it even sort of is offsetting the cost to the families outside of correctional settings, where they're sending money to their incarcerated loved one to pay for healthcare and pay for essential needs, as she highlighted.
I want to point out also that there have been a few evaluations of copays in certain facilities that have found that the burden of administering copays actually outweighs the revenue generated from them. So it's not that it's even an effective cost-sharing strategy. It's either costing the prison system more money, or it's not being appropriately administered so that people's right to healthcare is being infringed upon.
Eve, I think you asked the question of what can be done. There are a couple entities, the American Medical Association, the AMA, the National Commission on Correctional Healthcare, which is a national body that's trying to create standards and oversight and accreditation for correctional healthcare, have put out statements that they think copays should not be used in these settings at all, and that if there needs to be systems to lower the cost of healthcare in corrections, there are other ways to do that that don't have these downside problems. And I also say, actually, the Department of Justice, in their broader work around fines and fees, are looking at copays as potentially an infringement on the rights of people who are incarcerated. So I actually think correctional systems probably should get out in the front of the Department of Justice potentially looking into the practice. So number one, I think copays should be eliminated. And number two, in a bigger question, we just need to normalize how healthcare is provided in correctional settings. It shouldn't be this siloed thing where there's not the same oversight. It's financed differently. We just need to normalize it. And then that will potentially not remedy all of the problems of the carceral state, but potentially improve them.
Great. Well, thank you both so much for being here. I really like ending on that note to think about how the system might change to better serve the health needs and allow the healthcare system to do the work that it needs to do. So I'm Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. And I've been speaking with Dr. Emily Lupez and Dr. Ben Howell about healthcare access in U.S. prisons. You can find a link to this article in the episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.